Good evening. Thank you for the privilege to present here today. I'd like to present a case of liver transplantation for a rare indication, cirrhosis due to graft versus host disease in a patient after sorry. Thank you, Professor. That's better. Liver transplantation for cirrhosis due to graft versus host disease after bone marrow transplantation. In these patients, after hematopoietic cell transplantation, there are many problems, especially in the early period after transplantation. Liver failure is one of them, and it may be due to acute graft versus host disease and other complications such as veno-occlusive disease, also acute hepatitis, and then the problems also appear in the later phase. This may be chronic hepatic graft versus host disease and other chronic problems as well. Our patient is a 20-year-old female. She underwent allogeneic hematopoietic stem cells transplantation for recurrent acute lymphoblastic leukemia. It was in 2010. The donor was her sister, and she developed graft versus host disease early after the stem cell transplantation, and she was quite successfully treated with steroids at the beginning, then with extracorporeal photophoresis, and she was followed up then, and in 2016 her primary disease was considered to be in complete remission, but then the chronic graft versus host disease presented with liver failure. She had a biopsy which confirmed cholestasis and vanishing bile duct syndrome. And then she was considered for qualification for transplantation, but unfortunately the patient refused the treatment. So she was in fact followed in ambulatory settings. And when she was 18 years old, she was referred to our center to hepatologists to reconsider her for qualification for transplantation of the liver. And the problem with the patient was she was not very compliant, and even after a successful qualification, she refused the treatment again. And eventually she developed a severe liver failure, which led to the compensation of the liver function. And she was admitted to our department in July this year. First treated with albumin dialysis, but it was not very effective. So in August, she underwent orthotopic liver transplantation. She finally decided to follow our recommendations and have transplantation. There was surgical problem with the patient because she received quite large liver So we had to decide whether to close the abdomen or leave the abdomen partially closed. But this decision was effective. These are the pictures of her liver and abdomen before the transplantation, and after the transplantation with liver like that, the abdomen was filled with the new organ, and there was a little bit of compression, but fortunately with delayed abdominal closure, there was no complications of the intra-abdominal pressure. Sorry, how to return? Okay. So, and these are the results of biochemical studies in these patients. So you can see that from 2019, she deteriorated, the liver function deteriorated. So there was a clear indication for the transplantation. This is the pathology of the explanted liver, cirrhosis with traits of cholestasis and vanishing bile duct syndrome, which is typical for the graft versus host disease. Okay, and I performed short review of the literature. The cases of transplantation for graft versus host disease are quite rare, so our experience is limited. There are many patients that were transplanted early in the childhood, and in fact the results are quite good, except some cases that have complications related to infections, and these cases resulted in death of the patients. Generally, the outcome of the transplantation in these settings is related to the time when the liver failure occurs. So the earlier it happens, the worse the outcome is. So in our patient, it is quite favorable that the patient had liver failure late after the hematopoietic stem cell transplantation. And these are the outcomes from these cases that were collected over the years. The median survival is a little bit less than 10 years. The outcomes are worse than the outcomes for other indications. And what is interesting, that the outcome is better after leaving donor liver transplantation, but these are, let's say, anecdotal cases, because usually these patients received grafts from deceased donors. Okay, and I have some questions. Maybe we can start discussion to answer these questions. There are no recommendations, so it is open to discussion whether we should treat these patients in a different way, try to choose a specific liver if it is possible, and what is the choice of immunosuppression. So these are the questions for the audience. Do you have any?
Thank you very much, Dr. Dr. Kalinowski. Very interesting case, quite very uncommon indication for liver transplantation. Yes, there's a question in the room.
Actually, I understand the patient was transplanted for vanishing syndrome, right? And retransplanted for graft versus host disease, right?
The patient, the primary disease was acute lymphoblastic leukemia.
Right.
So the patient was transplanted when she was 8 years old. And then graft versus host disease occurred with hepatic presentation, leading to liver failure. And this was the indication for transplantation of the liver.
So after transplantation, she was all right, right?
It is only 1 month of the follow-up, so she is all right.
And were there any other signs on or laboratory data indicating graft versus host disease in terms of microchimerism, or did you look at it?
We have no data from the early period that will show what was the outcome in terms of chimerism, but the confirmation of the liver disease was in liver biopsy that was performed in 2017, so quite late after the stem cell transplantation, and it showed typical presentation cholestasis with vanishing bile duct syndrome.
All I'm saying, the patient was transplanted for cirrhosis, but I don't think there is convincing evidence of graft versus host disease, unless you've done some study on microchimerism or DNA in the graft and in the host, which may come from bone marrow transplantation, of course.
Graft versus host disease in these cases is diagnosed because this is organ-specific presentation. So in the liver, it is based on the biopsy. And also, usually the liver is not the only organ affected. So usually it starts with the skin. The liver is the second or the third organ commonly affected. So if we have another symptoms that are typical to graft versus host disease, especially in the chronic form of the graft versus host disease, it is generally enough to diagnose plus biopsy.
I think you make the point that the diagnosis of GVH is quite complicated, and roughly this patient, if I saw well, has been listed 1 year ago, and so she waited 1 year on waiting list before current transplantation. So yeah, roughly she was transplanted now for acute and chronic liver failure. The
problem with the patient was that there was really a lack of compliance with our recommendations. So during this period, in fact, starting from 2017, when the disease was diagnosed, the patient refused several times the treatment that was offered. And it was also the case after she was listed. So
roughly here we are in a salvage transplantation in a young patient, roughly, which is totally understandable. I think you raised a very interesting question on immunosuppression. What was your choice here in this patient compared to traditional immunosuppression you do for other indications of liver transplantation?
In fact, we have started with standard approach. So the patient received tacrolimus, MMF, and initially prednisone. But
this is your classical immunosuppression
yes.
in other cases.
Yes,
Okay.
this is. But of course, this is a special situation because we have a primary disease that is an neoplastic disease. So we try to minimize the immunosuppression. Of course, it is more a problem in the early graft versus host disease and early liver failure after hematopoietic stem cell transplantation, because the risk of relapse is higher. But anyway, we try to minimize the risk of relapse.
The challenge here will be that she's not compliant, so that you have to follow that, because the risk is that she won't take her medication, and again, you will go to another problem.
That's right. That's interesting because, in fact, in these patients, maybe not the patients with the liver failure and transplanted for the liver failure in these settings, but generally in chronic graft versus host disease, the situation when we discontinue immunosuppression is beneficial for them, and the survival is better if there is even maybe minimal graft versus host reaction.
Interesting case. Any other comment? Okay.
Okay, thank you very much.